Good evening and welcome. I'm Dr. Alessio Fasano, visiting professor of pediatrics at Harvard Medical School and chief of pediatric gastroenterology and nutrition at Massachusetts General Hospital for Children and director of the Center for Celiac Research and Mucosal Immunology and Biology Research Center at Massachusetts General Hospital in Boston. I'm also the chair of today's program, which will focus on gluten-related disorders, facts and fallacies. With the next slide, I would like to introduce the faculty. Dr. Stefano Guandolini, who is Professor Chief of the Division of Pediatric Gastroenterology at the University of Chicago and founder and the Medical Director of the Celiac Disease Center at Commonwealth Children's Hospital in Chicago. Dr. Joseph Levy, who is Professor of Pediatric and Director of the Division of Gastroenterology at the New York University School of Medicine in New York City. Dr. Hill, who is Professor of Clinical Pediatrics at the Ohio State University College of Medicine and Session Chief of Pediatric Gastroenterology and Nutrition at Nationwide Children's Hospital in Columbus, Ohio. And finally, Pam Curidan, who is a registered dietitian at the Center for Celiac Research Growth and Nutrition Clinic in Baltimore and also at Massachusetts General Hospital for Children in Boston. I would like to take the opportunity to thank NASPGHAN Foundation for sponsorship this webinar and to the American Academy of Pediatrics for collaborating with us and to Quest Diagnostic, which provides support for this program. Now a few quick instructions. We plan to highlight the content on the slides, but after the program, we encourage participants to download the full slide set using the link at the bottom of the web page. When you scroll down, you will also see a couple of interactive areas beneath the main window. During the course of this webinar, we will be conducting 4 participants' polls. Please do not respond to them until we present the polls during the program. You will also notice above the poll area is a questionnaire. You may submit questions at any time during the webinar. At the end of our presentation, we will answer as many questions as possible. Now, with the next slide, let's review the objective of the course. So our main 3 objectives are to identify clinical, epidemiological, and diagnostic characteristics of celiac disease with allergy and gluten sensitivity, to learn the most cost-effective means of testing gluten-related disorders, and finally to list similarities and differences in implementing a gluten-free diet for the 3 different forms of gluten-related disorders. Now, with the next slide, let me introduce the first speaker, Stefano Guandolini, that will discuss about celiac disease. Stefano?
Thank you, Alessio. So it's my duty to go through celiac disease within the next 11 minutes, and I hope you'll be following me. Again, as Dr. Fasano said before, we are going to go quite quickly, I guess, through most of these slides, but you're welcome to peruse all of them later on. Okay, so in the next slide, number 5, you will see a definition. We know celiac disease is actually the most common genetically induced food intolerance worldwide, with a prevalence of about 1% and actually growing. It's an autoimmune condition that is triggered by the ingestion of gluten in genetically predisposed individuals and causes an inflammatory damage of the mucosa to the small intestine, resulting in a variety of clinical presentations, not just GI. And as many of us know, if left untreated, may lead to a number of complications and even to increased mortality. You'll see in the next slide a brief scheme of the pathogenesis of celiac disease. Once again, we won't have the time to go through all of this. But just as a quick reminder, when you and I ingest gluten, our intestine is not able to digest it fully. So some gluten peptides remain, and they are able to cross the intestinal epithelium, reaching the submucosal compartment. There, if you have celiac disease, they are attacked by an enzyme called tissue transglutaminase that will change them and modify their charge so to make them perfectly suitable to be lodged into the HLA-DQ2 or DQ8 molecules that are presented on the surface of the antigen-presenting cell. And this is crucial because if you do not possess HLA-DQ2 or DQ8, and you cannot express them on the surface of the antigen-presenting cell, then you won't develop celiac disease. And once the gliadin peptide is lodged there, it's presented to the T-cell lymphocytes, and this begins the cascade of immunological events that leads to the destruction of the intestinal epithelium. So the genetic factors, HLA and DQ2 and DQ8, as you can see, are really necessary. But as you will see in the following slide, they are not sufficient. In fact, the general population of the U.S. is comprised for about 30-35% of people that present these genes, yet they don't develop celiac disease, not all of them at least. Only a small minority, that red dot, goes on and develops celiac disease, so clearly other genes are necessary. Once your intestine is inflamed, the next slide will show you how children would present. Now, this is a presentation that we all were very familiar with a number of years ago. It has become less and less common, but we still see some of these children. These are patients of mine, and you see them with the classical presentation, the large abdomen, the emaciated buttocks and legs, and even some dyscrasic edema at their feet. But as you see in the next slide, this is basically what still we call the typical gastrointestinal presentation. It's a combination of various symptoms, the most prominent of which is definitely diarrhea. Vomiting is also a prominent symptom, especially in young children, and this leads obviously to failure to thrive or weight loss, and is accompanied often with abdominal bloating or pain, and even with constipation, although this might appear to be counterintuitive, really. But you'll see in slide 10 now that celiac disease goes well beyond the intestine. In fact, we have a number of atypical or extra gastrointestinal presentations that are listed here. I certainly don't have the time to go through all of them, but this list is important as it reminds you that your degree of suspicion for celiac must be high, even in conditions that apparently may seem to have nothing to do with it, such as recurrent headaches or behavioral changes, psychiatric disorders. I saw no later than this afternoon a new patient coming to my attention with a new diagnosis of celiac who actually came to be diagnosed. She's a girl of 17, after a couple of years of anxiety, panic attack disorders that completely regressed once the diagnosis was reached and she was on gluten-free diet. So this leads us to the first of our polling questions. If you go to the next slide, basically the poll question is in the main window, and the area to submit your response is located beneath the main window. You may need to scroll down to see it. So simply make your choice and hit the vote button. We will report the results of the poll in a few minutes. So the question is this. Patients with potential for celiac disease, potential celiac disease, they do have what? A normal biopsy, but positive serology, a damaged mucosa, but have no symptoms, a damaged mucosa, positive serology, but do not possess neither DQ2 or DQ8, or a normal biopsy, negative serology, but they are first-degree relatives of celiac patients. All right, so I give you a little time to vote, and we go to the next slide, which will actually be helpful if you haven't voted yet, because it will tell you. In fact, because of the different presentations and combinations of symptoms, serology, different degrees of intestinal inflammation, we now classify celiac patients in 5 different groups. The first one is the typical that you have seen before, those children that were so sick. They have a positive serology. They are typically young children. They do have the gastrointestinal presentations we talked about, and their pathology shows changes that we call as MARSH 2 or 3, basically pretty advanced intestinal damage, even with complete villus atrophy, which is MARSH 3. Then we have the atypical patients that have the extra gastrointestinal presentations, the ones we quickly went through. Anemia, short stature, etc. They can have any degree of intestinal damage. The patients with silent celiac disease are those who are positive serology. They can belong to any age. By definition, they have no symptoms, so they feel well, and we all have seen several of them. But if you do the biopsy, you will see that the intestine is quite inflamed, MARSH 2 or 3. And it is the potential that the polling question was about. These patients have a positive serology, can be of any age, and in terms of symptoms, they may have no symptoms, or they may have GI or even extra GI symptoms. But their pathology, interestingly enough, is almost completely normal or completely normal. So we call them MARSH 0 or 1 being just an infiltration of intraepithelial lymphocytes. And finally, we have this category of latent, which I'm not going to focus on because this is just patients that had celiac disease and then for some reason apparently, quote-unquote, grew out of it. In fact, they seem to have a normal mucosa, but they previously had a gluten-dependent enteropathy. All right. So I guess at this point in time, Dr. Fasano, if you want to give the results, let's get the results of the polling question.
Sure. 48% of the participants answer A, i.e. have a normal biopsy but positive serology. 15% answer B, have a damaged mucosa but have no symptoms. 6% give as a correct answer the C, have a damaged mucosa, positive serology, but not possess neither DQ2 nor DQ8. And finally, the remaining 31% answer D, have a normal biopsy, negative serology, but are first-degree relative of celiac. Stefano, back to you.
Okay, well, that was very interesting. So really a good portion of the listeners, the followers, actually got it right. Okay, so we go to the next slide now, showing clearly the association of celiac disease with a number of conditions. Autoimmune disorders are prominent, and especially among them, type 1 diabetes and autoimmune thyroiditis are well known to be associated with celiac disease, with a prevalence ranging around 5 to 10%. But first-degree relatives of celiac patients also have a higher prevalence of this condition. And then finally, some genetic syndromes, the most common of which is Down syndrome. If you go to the next slide, therefore, it's a kind of a logical consequence of what we've been saying so far. Who should be screened? First of all, subjects that are symptomatic. Those who have suggestive gastrointestinal complaints, as you see in the first part of the slide, and those who have extra gastrointestinal manifestations that once again are reported here. So in the next slide, you see that even subjects that may be asymptomatic need to be screened because they are at increased risk of celiac disease. Once again, those who have autoimmune conditions, the first-degree relatives of celiac patients, and those that present those rare genetic syndromes like Turner-Williams, but the more common one, which is Down syndrome. So after this brief overview of celiac disease, at this point in time, I think I need to ask Dr. Joseph Levy to go on with the next slide. Yossi, please.
Thank you, Stefano. And good evening, everyone. We're going to talk about some of the important clinical manifestations of wheat allergy, which go beyond gluten intolerance and non-IgA-mediated gluten specific immune reactions, which are what celiac disease are. We'll talk more about the IgE-mediated type of allergies. And important to remember in the definition that for something to be considered an allergy, an immune-mediated mechanism has to be at play. And that's what makes the big difference between intolerance and allergy. And not every immune-mediated reaction is through IgE, but the ones that we will talk today are mostly IgE, and the entity of eosinophilic esophagitis is more complicated and probably IgE and non-IgE mediated. It is important to remember that food allergy is most common in the first year of life, and many children that are highly allergic initially will develop tolerance over time, and will end up sometimes being able to consume the foods that give them significant clinical reactions initially. Wheat needs to be remembered as one of the 10 most common allergens in every survey that is done. There are many difficulties in trying to establish the real frequency of food allergies, and especially when it comes to wheat, mainly because there is a big difference between the discrepancy between what parents report and what objective test measurements we have to determine that somebody is indeed allergic. And the most strict definition would be, of course, the double-blind placebo-controlled trial where somebody actually is proven with objective means to react specifically to a particular allergen We don't do that very much in clinical practice, and therefore it remains a big problem in terms of the accuracy of many of our surveys. The prevalence rate in the first 3 years ranges from 3 to 8%, so it's a significant clinical problem. On slide number 20, I want to just briefly go over one of the most interesting new entities that we are all confronted in pediatric gastroenterology, and that's the entity of eosinophilic esophagitis. Certainly seems to be increasing in incidence worldwide, and very often it presents initially as with the same overlapping symptoms of acid reflux, except those patients do not respond to the usual GERD measures and peptic control with antacids. We need to have a high incidence of suspicion for children that have feeding aversions. They have dysphagia, and the older children, they might present actually with a food impaction due to the changes in motility and sometimes stricturing that occurs in the esophagus. How do you make the diagnosis? Only with endoscopy and biopsies, and are now different entities in that interesting group of disorders where you can actually have eosinophilic disease that respond to acid suppression as opposed to eosinophilic esophagitis, which is a lifelong condition as we understand it now. On slide 21, you'll see the other important entity that fortunately is not a condition that we see very often in children, since in order to have Baker's asthma, the antigen has to be inhaled. So this is probably the most common of the conditions associated with an occupation, and that entails bakeries and anywhere in milling, in the milling process where you have the particulates in the air which workers can actually inhale. There have been some cases where the inhalant particles are brought home, and some children have been sensitized, and their respiratory symptoms have been aggravated as a result of inhaling some of that wheat brought by one of the parents home. The symptoms of Baker's asthma includes really typical asthma symptoms with wheezing, chronic congestion, conjunctivitis, rhinitis, all of the exposures that you can get directly over the membranes. And now it's time for our second polling question on slide 22. And here's the question. Are you aware of the clinical entity of wheat-dependent or even food-dependent exercise-induced anaphylaxis? And here are the two choices, yes or no. Give you some few minutes to answer the poll. And on slide 23, I present some of the highlights of this entity, which is very important because we seldom think about it. And in order to identify it, you need to have a very high index of suspicion and actually be familiar with the fact that there are patients where the only manifestation, clinical manifestation of their wheat allergy is if after ingesting the allergen, they engage in physical activity. And even though initially some of these reports came after patients actually engage in significant activities, strenuous activity like running in a race or even swimming in a race, it turns out that in order for you to develop this severe allergic to the point of progressing to anaphylaxis reaction, some of the exercises and some of the reports are as mild as walking up a hill or even playing a game of ping pong. What is very crucial here is that there is a window of about 2 or 3 hours that have to elapse between the ingestion of the food and the exercise. Later than that, you're safe because whatever processes take place in the gut, which are believed to be due to permeability and ingestion of antigen, take place within that window of 1 to 2 hours. So those patients are presenting sometimes with severe anaphylactic reactions, where if you do the typical screening for food allergies, you will not find anything. But if you keep in mind that some of the reaction happen after that subject engage in some activity, you might be able to then put in place the proper testing and or do the proper advice and recommendations. We are ready, Alessio, for the polling question results on slide 24.
Yes, indeed, interesting. 29% of the audience is aware about this clinical entity, while the vast majority, 71%, is not. I want to take this opportunity to remind everybody that you can submit your question at any time, not necessarily toward the end of the webinar. So if you have a question, just go ahead and submit them. So, Yossi, back to you for the comment of this interesting outcome.
So this is something that we all need to be aware, therefore, that this can happen not only with wheat, but apparently with other foods. And the list is long, includes many, safe foods and proteins, even found in fruits in some of the reports. And it's sometimes dose-dependent, clearly, and in some cases the intensity of the exercise is what ends up triggering the serious release of histamine throughout the body. The timing of the exercise, as I mentioned, is crucial, and that window of safely doing it after 4 hours, if this is suspected, can be safe for the person. There are other factors that modify it, and the most important one is aspirin. It turns out that aspirin increases permeability in the gut, and that by virtue of increasing the absorption, it is believed, of whole antigen, sometimes you have the opportunity to set in motion this very specific and very, very clinically intriguing condition. I'm ready now to give the floor, so to speak, to Alessio, who will be talking about non-celiac gluten sensitivity.
Thank you, Yossi. So of the three forms of gluten reaction, the non-celiac gluten sensitivity is the so-called new kids on the block. And we realized the existence of this new entity on the field, mainly because of the experience with our patients. In the next slide, slide 27, it outlines an interesting trend in the last decade in terms of three popular diets. You see in yellow a low-carb diet, and then a fat-free diet in red, and a gluten-free diet in blue. I believe that the graph is self-explanatory how the gluten-free diet was not popular whatsoever at the beginning of this millennium, and starting from the 2007-2008, the line of the gluten-free diet popularity crossed the other two, and has been increasing ever since to reach a market of quite impressive dimensions. Roughly $6 billion in sales are projected by 2017. Of course, it's unthinkable that this market is sustained purely by people with celiac disease, given the fact that the projected number, if everybody will be diagnosed, will be roughly 2.53 million in the United States, and definitely our current, estimates is that, less than 10% of people with celiac disease have been diagnosed. So who makes up this market? The next slide, slide 28, will pretty much, give you an idea how the gluten-free market and the consumers are divided by mainly two major categories. The one that embraces gluten-free diet for medical necessity, and the one that do not have that medical necessity to be on a gluten-free diet, i.e. the occasional consumers. They probably will make the vast majority of the people that drive this gluten-free market nowadays. Of course, we're interested in this webinar and for our clinical interest to the first category, the ones that have to go on a gluten-free diet because otherwise they will develop signs and symptoms that will affect in a negative way their quality of life. You heard about already the allergic reaction to gluten with allergy that Yossi just highlighted for us. Stefano outlined the autoimmune response to gluten. That is celiac disease. And here we have clear estimates of what is the prevalence of these two conditions because we have good biomarkers to have an idea how frequent they are. We know that roughly 1% of the general population worldwide is affected by celiac disease, much less with allergy, depending on the age, but the average is 0.2, 0.4. So the question is, what is this third entity, what we're talking about? And of course, we don't have, clear understanding how frequent this condition in lieu of the fact that the diagnosis right now indeed is only by exclusive criteria. The next slide 29, indeed highlight what we now define as gluten sensitivity. There is a lot of confusion in terms of nomenclature and definition, but there have been a couple of attempt by different groups to really put a little bit of order and, definition on entity that right now is universally acknowledged to exist, but there's still a debate far to be settled of what exactly gluten sensitivity or non-celiac gluten sensitivity is. What we know for sure is what is not. So it's a condition in which there is a reaction to gluten, and for sure the allergic and autoimmune mechanism have been ruled out. So in other words, with allergy and celiac disease needs to be ruled out. So people with symptoms that are triggered by gluten ingestion and that will be relieved by elimination gluten diet, they are negative for immunoallergy tests for wheat, negative for celiac disease serology, negative for biopsy, and they may sometimes have the presence of the old biomarkers of exposure to gluten, the anti-gliadin antibodies. Symptoms, they overlap with the others. And the resolution of the symptoms following implementation of gluten-free diet, possibly, as Yossi was mentioned, even for wheat allergy on a double-blind fashion. The next slide 30, we summarize a list of symptoms in order of frequency that have been reported in individuals suffering gluten sensitivity. Top of the line here is abdominal pain. Almost 2/3 of patients suffer abdominal pain. And then you see the list that goes down with eczema, headaches, foggy mind, and so on and so forth. If you go through the list, you realize immediately that it's not possible, really, on a pure clinical ground, distinguish gluten sensitivity to other forms of gluten reaction, particularly celiac disease. So with the next slide, this slide 31, we have what is being proposed new classification of gluten-related disorders, mainly based on the pathogenesis. So again, if we're talking about autoimmune reaction, we talk mainly celiac disease with the clinical forms, as Stefano has mentioned, typical, atypical, potential, latent, and silent. There are forms that are specifically targeted the nervous system with the gluten ataxia and the skin, dermatitis perdiformis. Then we have the allergic reactions with allergy in its different forms that Dr. Levy discussed before, and then this third non-autoimmune, non-allergic, probably based on an innate immune reaction. Now there are several reports in the literature that point in that direction, but it's still a work in progress. And again, as you see here, while we have valid solid biomarkers for celiac disease and wheat allergy, we still miss, these diagnostic tools for gluten sensitivity, and hopefully this will be, identified and validated soon. So how do we make the diagnosis of celiac disease nowadays? And what are the take-home messages? They are highlighted in the next slide, slide 32. What we can tell right now is not much, but we can definitely, with a great level of confidence say that gluten sensitivity is not rare, cannot be distinguished on a clinical ground from other forms of gluten reaction, particularly celiac disease. Can present in a very vague, non-specific symptoms. And I believe that of this slide, the next bullet point is by far the most important. A gluten-free diet cannot be considered if we don't have rule out already celiac disease and wheat allergy and other forms, the causes of the patient's symptoms. So before to consider a trial with a gluten-free diet, it is a must that these other forms of gluten reaction needs to be ruled out. Otherwise, we will deprive ourselves of biomarkers that will not be reliable anymore if the patients embrace the diet before the diagnosis. The last bullet point I put for myself mainly because I was very skeptical about the existence of this form, and I have to change my mind because if you listen to your patients, they will tell you a great deal that you may learn, a much later time. With that, I will turn now to a very important topic that will be covered by Ivor Hill in the next slide, the diagnosis of celiac disease versus allergy versus non-celiac gluten sensitivity. Ivor, please.
Thank you, Alessio. So let's begin with slide number 34. And, as in any case of clinical medicine, to make a diagnosis of a condition, you need a clinical suspicion. You would usually follow this with maybe some initial screening tests, more definitive tests, and then you would initiate therapy and monitor response. And these principles apply very nicely to celiac disease, wheat allergy, and non-celiac gluten sensitivity. So I'm going to begin with celiac disease, and obviously once you have a clinical suspicion, the first thing we're going to do is some serological tests, which we have available to us. And on the next slide, number 35, this will show you the tests that we have are commercially available to us for testing for celiac disease. These include the anti-Gluten antibodies, which are available in both an IgA and an IgG component, the endomysial antibody, which is offered as an IgA antibody but can be available in an IgG upon request from several laboratories, the tissue transglutaminase, which comes in an IgA fraction but is also available on request as an IgG, and then the newest test, the deamidated gliadin peptides, which are usually offered as both an IgA and an IgG antibody. Now, if we look at these tests, they have various accuracies and sensitivities. Certainly, we now know that the anti-Gluten antibodies are the least sensitive and specific, and they also have a problem that they are widely variable in their sensitivities and specificities. The endomysium antibody is very sensitive, in excess of 90%, and highly specific. Usually the numbers quoted are in the region of 98-99%. The tissue transglutaminase IgA antibody is even more sensitive, somewhere in excess of 95% by most tests, and slightly less specific than the endomysium, but certainly 97-98%. And the deamidated gliadin peptides, not quite as sensitive or specific as the endomysium and tissue transglutaminase, but certainly way better than the anti-Gluten antibodies. Probably in the region of around 90% sensitivity. The deamidated gliadin peptide IgG is very specific, again rivaling close to that of the endomysium antibody. So let's go to the next slide, number 36. And here's a poll question. When testing for celiac disease, do you request A, a celiac panel, or B, a specific serological test? So if you'll just go to your buttons and choose your test, we'll move on slowly. And I'm going to go to slide number 37. So how should we test? Which test should we use? So looking at the recommendations of the various guidelines that are out there, there are a set of guidelines from NASPGHAN, from NASPGHAN, the European Society, from the American Gastroenterology Association, and now recently from the American College of Gastroenterology. Every one of them strongly advocates that the anti-Gluten antibody tests are no longer used for routine testing for celiac disease. They're just not reliable enough. There's a lot of consensus amongst the various guidelines suggesting that the single best test to use would be a tissue transglutaminase IgA antibody. It certainly is the most reliable test available and is cost-effective. If we could go to the next slide, number 38, we do have to ask some questions. What about a serum IgA level? Should this be a routine test when testing for tissue transglutaminase because it's based on an IgA antibody? Now, as we know, isolated IgA deficiency occurs in about 1 in 500 people in the general population, but in the celiac population it's much more common, occurring in about 2 to 3%. So this is important to know because if you are selective IgA deficient, the tissue transglutaminase IgA antibody is of no value to you at all. The NASPGHAN and the SPAN guidelines recommend that you consider doing a serum IgA level on every child that you're testing for tissue transglutaminase, whereas the American Gastroenterology and American College of Gastroenterology are slightly less forceful about this. They suggest that it may not be cost-effective. And I will tell you that there's a paper about to come out in the near future that looked at over 7,800 people that were from the general population who were screened for celiac disease and had a serum IgA level taken on all cases. Only 2 cases of celiac disease would have been missed out of over 7,800 cases if it's a routine serum IgA level had not been taken. And remember, these are asymptomatic individuals. So we may have to question whether it's cost-effective to do a serum IgA on every case. If you do happen to be IgA deficient, what test should you use? Well, it's recommended that you ask for a tissue transglutaminase or an endomysium antibody of the IgG subclass. These are not as good as the IgA, but there is some evidence suggesting that if you are IgA deficient, they are even better than if you are IgA sufficient. So maybe they have a more specific role to play in those that are IgA deficient. There's also the question about the young child. There is some evidence suggesting that children under 2 years of age, when you use the tissue transglutaminase or the endomysium antibody, they're not quite as sensitive as they are in the older child, and therefore it's been suggested that you should use these in combination with another test if you're young, under 2 years of age. Current recommendations are to add a deamidated gliadin, IgG, to the tissue transglutaminase. I will tell you there is some recent evidence coming out suggesting that this may not be true, that children under 2 years of age may not require additional testing as their results are just as good as in the older child, but we're going to wait for that. The question always comes, should you do HLA testing in individuals? And as we've heard, HLA tests for the DQ2 and DQ8 are helpful, but not in the initial diagnosis. All the guidelines say they should not be used for routine diagnosis, and they should rather be reserved for difficult cases or where there's a diagnostic dilemma. The only use of the HLA tests are if they are negative, because that virtually takes celiac disease off the table. But as you heard from Dr. Guandolini, if they're positive, it doesn't mean you are going to have celiac disease, as you may be one of those 30% of the general population who has an HLA DQ2 or DQ8. We still recommend that a definitive diagnosis requires an intestinal biopsy. So while these tests, serological tests, are pretty reliable, they're not 100% sensitive or specific. So who should get a biopsy? Certainly those that are serology positive. But remember, because these tests are not 100%, if you have a high clinical suspicion for celiac disease and your tests are negative, you should still consider doing an intestinal biopsy to confirm the diagnosis. If we could move on to slide number 39, I'm asking Alessia to give us the results. Do you test A for a celiac panel or B a specific serological test? Alessia, if you could give us the results.
Sure. 36% of the audience choose A, celiac panel, and the remaining 64% choose B, specific serological test. Ivor?
Thank you. So I'm very pleased to see the majority choose a specific serological test. And just to remind the others, cost-effective, it's probably best to do just a single TTG as the single screening test. Moving on to slide number 40. Who should be tested? We've already heard from Dr. Guandolini. In symptomatic cases, certainly those with typical gastrointestinal symptoms, serological testing should be one of the first tests you consider. In non-gastrointestinal symptoms, it certainly should become a consideration if you can't find an obvious cause for their symptoms. The question of whether we should be screening asymptomatic individuals who belong to at-risk groups is still being debated. Certainly NASPGHAN and NASPGHAN have recommended this be a consideration. But if you look at the adult literature, the American Gastroenterology Association and the American College of Gastroenterology, they are recommending that this may not be a good strategy and suggest rather that you are aware of the fact that these individuals are at increased risk and consider screening them should they ever develop any symptoms. Here's our next polling question on slide number 41. In a patient with symptoms of celiac disease but negative serological tests, would you advise a trial of a gluten-free diet? Two simple choices, yes or no. If you would go to that, we'll move on to slide number 42 and come back to the polling question. So turning now to wheat allergy and non-celiac gluten sensitivity, the diagnosis of wheat allergy, usually allergists will do skin prick tests or allergen-specific IgE antibodies and blood tests. But even these are not 100% accurate, and the only way of being completely sure that you have a wheat allergy is based on an oral wheat challenge, usually a double-blind, placebo-controlled food challenge. Non-celiac gluten sensitivity, as we've heard, is really a diagnosis of exclusion. You need to make sure that you have negative tests for celiac disease and that you've completely excluded wheat allergy. And then you're required to undertake a double-blind, placebo-controlled food challenge to demonstrate that symptoms recur when they are given gluten and disappear again when the gluten is withdrawn. And if that is the case, you can then confidently diagnose non-celiac gluten sensitivity. So turning now to slide number 43, this is the polling question results. In a patient with symptoms of celiac disease but negative serological tests, would you advise a trial of a gluten-free diet? Alessio, can you tell us what the panel said?
Yes, 45% of the audience said yes, and the remaining 55% no.
Okay, so about a 50-50 split. Again, just to remind everybody, if you are going to initiate a gluten-free diet, you need to make sure that you have absolutely excluded celiac disease and that wheat allergy is unlikely, and then you're going to have to do a double-blind placebo-controlled food challenge to confirm your diagnosis. So slide number 44 just provides, I won't go through this in detail, it provides a very nice differential of the features between celiac disease, gluten sensitivity, and wheat allergy. We've gone over these before, so I won't take too much time here. And moving on to slide number 45, I just want to give a summary of the diagnosis. Remember, celiac disease requires a clinical indication, a serological test, followed by an intestinal biopsy, and then the response to the gluten-free diet is very important to really finally confirm the diagnosis. Wheat allergy requires a clinical indication, possibly the use of skin prick tests or allergen-specific IgE antibodies, and to be absolutely sure, you would need the oral food challenge. And as Alessio mentioned earlier, non-celiac gluten sensitivity is really a diagnosis of exclusion. Again, you have to have a clinical indication. You must have excluded celiac disease based on serology or even biopsy, and you must make sure that you are not dealing with a wheat allergy, and then you are required to undergo a double-blind placebo-controlled food challenge. With that, I'm now going to hand the speaker over to Pam Curitin, who's going to talk to us about treatment. Pam?
Thank you, Ivor. With just a few minutes to cover what I consider the most important topic of this evening, I would like to start with one of my main take-home messages, and that is that newly diagnosed patients really need to be referred to a knowledgeable dietitian, not the internet, for their nutrition counseling. On my first slide, 47, the only treatment for celiac disease is a strict, lifelong gluten-free diet. And that means avoiding those gluten-containing grains of wheat, rye, barley, and cross-contaminated oats. As with celiac disease, the only treatment for non-celiac gluten sensitivity or other gluten-related disorders is also the gluten-free diet. But for how long and how strict, those questions yet to be studied. On my next slide, taking a look at some of the foods that we have to eliminate on the gluten-free diet, there are the obvious sources of gluten that we think of. We think of breads, pastas, pastries, but gluten-containing ingredients, especially wheat, are widely used in processed foods. Gluten is found in less obvious food items such as soy sauce, licorice, candy, soup bases. So reading labels can become very confusing, and grocery shopping can take hours. In 2006, the Food Allergy Labeling and Consumer Protection Act, or FALPA, made this task much easier by requiring companies to identify in plain English the 8 most prevalent food allergens, wheat being one of them. If wheat is used as an ingredient or part of an ingredient, it must be identified with either parentheses next to the ingredient or listed under a contains statement, capital C, contains. This makes grocery shopping much easier as wheat is no longer a hidden ingredient. As nice as this is and as helpful as this is, unfortunately it's not perfect. Wheat is the only gluten-containing grain that's covered under FALPA. So barley, rye, and oats are not is listed under the contains statement, but neither are they hidden ingredients. Meat, poultry, and egg products are covered by the USDA and not the FDA. However, about 90% of the manufacturers polled will voluntarily follow the FALPA guidelines. FALPA covers ingredients that are intended to be in the product, but not the cross-contamination or the contamination of the product. Oats are a good example of this. So oats can actually be contaminated with wheat, but you won't see wheat listed under a contained statement on a box of Quaker Oats. That's because it's not an intended ingredient in the product. Over-the-counter prescription medications are not covered, and alcoholic beverages are not covered under FALPA. Now, the second part of this ruling mandated that the FDA come up with a definition for the term gluten-free. And in slide 49, we can take a look at what the proposed guidelines are for the gluten-free labeling law, but unfortunately, we still don't have that definition yet. So at this time, we really don't have a definition for the term gluten-free. Once passed, so we assume that the proposed guidelines will include a specific definition that foods must meet all 4 of the following criteria in order to be labeled gluten-free. It cannot contain the prohibited grains that we talked about, and it can't contain an ingredient made from the prohibited grains that has not been processed to remove the gluten, or if it contains a prohibited grain ingredient that's not been processed to remove the gluten and exceeds the content of 20 parts per million. And in the final ruling, we believe that the amount of gluten that can be in a product will be less than 20 parts per million gluten. This would put us in line with what the rest of the world is doing with their gluten-free labeling laws as well. The Food and Drug Administration has passed this on to the White House Office of Management and Budget, so we're still awaiting the final ruling, and hopefully we will see that soon. Once that's enacted, this rule will give the gluten-free consumer much more confidence in the safety of the gluten-free products that they're purchasing. On my next slide, slide 50, and I think as we've heard Alessio talk about the reasons why people follow the gluten-free diet, the general public has this perception that it might be a new weight loss plan, that for some reason they think if we take gluten out, it would be a healthier way of eating. Some argue that everyone should be eating a gluten-free diet. However, the negative impact of the gluten-free diet on nutritional status has been well documented. Studies have shown that long-term adherence to a gluten-free diet has been associated with poor vitamin status and weight gain in certain groups of patients. The gluten-free diet can be missing important nutrients like fiber, iron, the B vitamins, calcium, phosphorus, zinc. These nutritional deficiencies then can lead to iron deficiency anemia, reduced bone mineral density, constipation. Most of the gluten-free products are not fortified and enriched as their wheat counterparts are mandated to be. So again, they would be missing those added B vitamins and iron. Historically, gluten-free foods have been higher in fat, sugar, and calories in order to achieve a desirable taste and texture. But today's manufacturers of gluten-free foods have found better ways to achieve those goals. So the content, the caloric content is closer to that of their wheat counterpart, but some remaining can be quite high in calories and thus producing that unwanted weight gain. Slide 51 helps us to look at what we need to discuss when developing a nutrition care plan, and a complete assessment is really required by a knowledgeable dietitian. A nutritional counseling session should include things like, of course, obviously the nutritional assessment, which would include dietary intake, including alcohol, nutritional supplements, medications, looking at the physical findings, the anthropometrics, the biochemical data, medical tests and procedures, and of course patient history, including their personal, medical, and health history, family medical history, and social history. Social history being who prepares the meals, the availability of gluten-free meals or access to gluten-free foods, and what kind of social and medical support that patient might have. The next slide talks about the quality of life, and to increase compliance to the gluten-free diet, the factors affecting that patient's quality of life must be addressed. The social and economic aspect must be considered, A study by Green found that individuals would intentionally cheat on a diet in social situations. Dining out, parties, and other functions outside of the home lead people to go off their diet. How available is the gluten-free food? In larger metropolitan areas, gluten-free foods are quite common in grocery stores today, but in some rural areas, the availability and selection may be quite limited. There's religious considerations, communion being one of them, and if the patient is aware of alternatives to taking wheat communion wafers, what's available to them. Eating away from home, as we talked about before in restaurants, when polled, 85% of those polled would intentionally go off their diet when eating in a restaurant. Schools pose difficulty for students. The Americans with Disabilities Act requires that schools make a reasonable accommodation for students who need a gluten-free lunch. However, many schools are resistant to this and are unaware of the rules and are often non-compliant. Hospitals also present some challenges to deliver the gluten-free meals. It's important when ordering a diet for the patient that the correct diet order is given. Oftentimes, when changing from one consistency, like a full liquid, to a soft diet, perhaps the gluten-free part is left off. So again, making sure that order is made clear. When queried about other reasons as to why patients were non-compliant, some of those reasons were the diet was too restrictive, it was uncomfortable in the social setting, too difficult, tasteless, or too expensive. And again, unfortunately, our gluten-free products do still tend to be somewhere between 3 to 5 times more expensive than their wheat counterpart. To conclude this treatment section of the program, I would like to again emphasize the importance of referring your patient to a knowledgeable dietitian so all of these issues can be addressed and again to assist with their quality of life. With that, I'll turn it back over to Dr. Fasano to provide a summary for the webinar.
Thank you, Pam. So if we move to slide 53, to summarize the content of this webinar that we had today with the key message we want to make sure that went through, starting with the fact that gluten can trigger celiac and other immune-mediated disorders like wheat allergy and non-celiac gluten sensitivity, so it's not, as we believed before, exclusive celiac disease as a reaction to gluten ingestion. The 3 forms of gluten-related disorder can clinically overlap and therefore cannot be distinguished just on a clinical ground. The prevalence of wheat allergy and celiac disease are well established because we have specific biomarkers, but the magnitude of non-celiac gluten sensitivity remains unestablished until we have validated biomarkers to help us with epidemiological study. If we can go to the next slide. The diagnosis of wheat allergy and celiac disease is based on specific screening tests, while the diagnosis of non-celiac gluten sensitivity, again, is based purely on exclusion criteria. As you heard, a gluten-free diet is the cornerstone of treatment of the 3 gluten-related disorders, but the way the diet is implemented differs really greatly from one form to another. And finally, I believe that it's extremely important to stress the concept that it's imperative to establish which form of the gluten reaction affects the patient before implementing the gluten-free diet, and this needs to be managed by a knowledgeable dietitian, as Pam stressed many, many times. I know that, the time was kind of limited to go to a wealth of information. We hope that we gave you a good overview of the spectrum of gluten-related disorder, but if you want to learn a little bit more about that, if you go to the next slide, there is a great opportunity coming up, and I want Stefano to share with you what this opportunity is all about. Stefano.
Thank you very much, Alessio. I think this was a very interesting webinar, and it shows that there is a real interest, and this is a gold mine of new fascinating conditions that are being now understood and worked on more and more. So we have organized in Chicago on September 22 to 25 the 15th International Celiac Disease Symposium. This is a manifestation that occurs every 2 years. It had been, in the last few years, it had been, for instance, in Amsterdam in 2009, in Oslo in 2011. The next 2 editions are already booked. The 2015 one will be in Prague, and the next one even in India. So this is your only opportunity to hear in this part of the world the experts, basically most of which you heard already tonight, but many, many others coming from both sides of the ocean will populate these 3 days. We have 2 separate tracks. One is called the Scientific Forum, mostly dealing with advancing research, and the other is the Clinical Forum, mostly dealing with clinical issues for clinicians and also for dietitians and patients. And again, we are going to cover all the issues that you've heard tonight and many more, and in a form which is interactive and with debates and high participation from the public. So you're all invited to go online and click on the register mark. Thank you very much.
Thank you, Stefano. If I can have the next slide also, if you're really interested to deep a little bit more your knowledge about gluten-related disorders, with the sponsorship of the NASPGHAN Foundation, there is going to be a book that will be published this fall, the Clinical Guide of Gluten-Related Disorders. Many outstanding scientists and clinical scientists are, contributing to this book, including all the speakers for tonight. So if you're really interested to learn a little bit more, this is your opportunity. This book is going to be probably the state-of-the-art of what we know about gluten-related disorders. And if we can move to the next slide, we have a series of extremely interesting questions that we're going to go through. Starting with the first one that is for Stefano Guandalini. If you have a patient with a TTG more than 200 negative within a biopsy, what would you recommend to the family? And also, what do you recommend when the TTG levels don't come down and they have additional autoimmune conditions such as type 1 diabetes? What would treatment recommendation will include?
Okay, well, thank you. These are actually 2 and even more complex questions. So to the first one, I would say if this child, because I think we are talking about children with a TTG extremely elevated but negative duodenal biopsy, so we are talking, if you remember, of a potential celiac. So this is a classical definition of somebody who has potential celiac disease. Now, I would say, first of all, if this patient has symptoms, I would definitely recommend a gluten-free diet, because even with a normal biopsy, this is celiac, and it is to be expected that the symptoms might improve on a diet. If the patient is, on the other hand, entirely asymptomatic, then we entered a shadow area, and there is no general consensus on what to recommend. So what I do, I explain to the family the situation. I tell them that in my book, this is potential celiac, which may develop into full-blown celiac disease, including an intestinal inflammation and also symptoms. This, in fact, has been found by several studies following prospectively these patients who wanted to stay on gluten. Depending on the series you read, about between 50 and 60% of them, or sometimes even more, if followed over the next 3-5 years, they would develop celiac disease. So I would tell the family that this is what they have to expect, but with a child being asymptomatic, really is essentially their choice. If they ask my opinion on what would you do if this were your child, I would probably go for a gluten-free diet, to be frank with you. Now, the second question, it's on a patient whose TTG levels don't come down and have other autoimmune conditions. Well, again, if the levels don't come down but were, almost, not extremely elevated, and possibly this is what we call a false positive TTG due to the presence of the other autoimmune condition. Type 1 diabetes does that all the time. So if the patient does not have celiac disease, if the celiac disease has been properly ruled out by biopsy and by the additional anti-endomysium antibodies, I would then not consider this be part of celiac, and I would just ignore the TTG. I don't think a gluten-free diet has any place in a situation like this. So I'll let you have my answers.
Okay, thank you, Stefano. The next one is for Ivor. Ivor, what do you do if the family already stopped gluten? How do you manage the diagnosis?
Yeah, this is a question that comes up frequently, and I think more and more we're all being faced with this, where somebody does a serological test, which may be the correct one or not. It's positive in the community. They start the child on a gluten-free diet and then send them to the gastroenterologist sometime later and say, does the child have celiac disease? So if It depends on which test was done. If it's an anti-gluten test, I would put very little store in it. If it's a positive TDG or a positive EMA, I would put more store in the value of that test. If the gluten-free diet has not been instituted for very long, a matter of a week or two, I would go ahead and organize a biopsy immediately. If the child has been on a gluten-free diet for a few months, chances are that the biopsy is not going to help you in that situation at all. This is when you're going to sit down with the family and have that discussion about how important it is to be sure of the diagnosis. I think if your elevated antibodies were very high and the child was symptomatic and had responded to the diet, that would make it an easier decision to just continue the diet without a biopsy. If the elevated antibodies were not that high and the symptoms were not that characteristic of celiac disease, you would need to sit down and discuss the possibility of putting the child back onto gluten and retesting and biopsying in the future if they develop symptoms. It's something you have to do on a case-by-case basis.
Thank you, Ivor. Now, the next question is for Yossi Levy. So, if there is a wheat allergy, even if it is of a class 1-3, should we avoid wheat in the diet?
Not necessarily. I think one of the important things to remember about all of our testings, whether it's patch testing, skin prick testing, and the RAS testing, even the CAP immuno testing with quantifying the specific IgE, none of them actually predict who is going to have a true allergic reaction when you consume the wheat. You have to remember that some of the extracts with which you make these allergens might not be necessarily the ones to what the patient reacts, and that some of the reactions, especially if the patient is atopic, they might have a lot of non-specific type of positive reactivity, even at 1 or 2, 3, so that you don't necessarily have to exclude that food absolutely. In other words, you have to be very individual about it, and if you're doing a screening as to what foods are you going to eliminate first in a child that has a whole variety of clinical syndromes, including the vomiting and the food aversion, etc., even if they don't have eosinophilic esophagitis, you might use the result of your skin testing as a guide. But it should be just a guide. None of these tests, unfortunately, are totally predictable.
Thank you. The next question is for our dietitian, Pam. Other than fiber, is a gluten-free diet adequate in nutrients such as a B-complex, iron, etc., by using gluten-free flour and quality diet otherwise? So, in other words, is there any need of any supplementation when you go gluten-free?
Well, again, if I was allowed maybe 5 or 6 more slides, I would have covered all of this. The gluten-free diet can be adequate in all the nutrients. It takes careful planning, the use of some of the ancient grains, the amaranth, buckwheat, millet, teff. Some of these grains are quite high in the B vitamins, the iron, fiber, a lot of the things that are missing from the traditional gluten-free foods, which are made with processed white rice flour and starches. So usually in the beginning, when there's damage and there's problem with absorption, oftentimes we will recommend a supplement to cover some of these areas that may be low due to the damage. But as the gut heals and the diet is balanced by using some of these other more nutritious grains, it certainly can be a very well-balanced diet.
All right, so there's the next question that I will take. Actually, there are a couple of participants that have the same question. It is true that wheat that we now eat today in the USA has been genetically altered. Also, I have heard that humans were not meant to eat wheat. Please comment on both. Well, listen to our agronomers. It is very unlikely that wheat went to genetic alteration during the past short decades, at least not during the time in which we've been witnessing an increase of the prevalence of celiac disease over time. So I know that there is a lot of buzz about the entire situation. There's been a press release 3 days ago from USDA that seems to alert that there is at least one such an evidence, but again, it's an isolated episode that still needs to be confirmed. As concerned that humans were not meant to eat wheat, that's probably true, given the fact that, during our 2.5 million years of evolution, humankind has been for 99.99% gluten-free. Gluten came into the picture only 10,000 years ago when we changed lifestyle from nomadic to settlers, and that's where the dawn of agriculture, with that, wheat came into the picture. So we do not have the capability to do with gluten what we do with any other protein, to completely dismantle the single element amino acids. So most likely, indeed, we are not really fit to deal with gluten on a general basis, but said that only a small percent of individuals exposed to gluten will have situations that will lead to these gluten-related disorders. Next question is for Ivor Hill. Does wheat intake affect serology results?
Not quite sure I understand what the...
So in other words, I believe that the question is, if you go gluten-free, can the serology results be affected by that?
Absolutely. I mean, if somebody has celiac disease with positive serology and goes on a strict gluten-free diet, we anticipate that those antibody levels will, over a period of time, revert, in most cases, back to normal. Some will still have slightly elevated antibodies, but the vast majority are going to return back to normal. The exact timing varies anywhere from 3 to 9 months in an individual, but if you have a titer that you can follow, you can see it coming down. If that answers the question, that would be my simple answer. If there was something else that the person needed to answer, I'll ask them to send that in again as another question.
Okay, actually, I have one more question for you. What does one do with a child that has a TTG IgG positive, TTG IgA negative, and total IgA is normal?
Right, so that would be less suggestive of celiac disease. I think, again, you would have to take the whole picture into consideration. What are the clinical features? I would not be willing to send that child for a biopsy just on that basis, but I'd probably look at other tests as well, and maybe this would be an indication for either doing an endomysial antibody or deamidated gliadin peptides, looking for additional information that might help you make the decision of whether you send that child for a biopsy.
All right. Stefano, this is for you. Would you take a patient off wheat with positive skin biopsy, I'm assuming for dermatitis perdiforme, negative serology, without a biopsy?
Okay, so again, as you said, the question should, I interpret it to be related to dermatitis herpetiformis. So if the positive skin test is somebody who has blistering skin lesions and that were documented to be DH, if this is what you're talking about and not a prick skin test for wheat allergy, then I think we have enough evidence. DH is responsive to a gluten-free diet, and this patient should be put on a gluten-free diet. I do not think that there is a need for intestinal biopsy, also in consideration of the fact that the prevalence of MARSH 0 to 1, so very low or absent damage of the intestine in patients with dermatitis herpetiformis is pretty elevated. It is not that all of them do have an intestinal biopsy lesion clearly documented as in celiac disease. So my answer would be absolutely yes, if the diagnosis is DH.
Got it. So for Yossi Levy, what is the best way to test for wheat-dependent exercise-induced anaphylaxis?
The best way is a history, and a history. And I know that one of the people listening to the webinar today asked, who wants to exercise after eating? A good question, but I don't know in your family if they told you never go back to the swimming pool as soon as you eat. They told me to wait at least an hour. And I wonder, in retrospect, whether that is somehow cultural memory of individuals that had their lunch or their barbecue and then went into the pool and had severe anaphylactic type or severe shock, because this picture is actually a picture of shock where you get hypovolemic and you might not necessarily even develop a pulmonary manifestation. So the best way when you get the history that somebody has had a severe reaction suggestive of food intolerance and you get in the history that did seem to happen after somebody exercised, especially there have been cases where these are professional athletes where this has happened and where they do want to exercise and they want to do that safely. What they do is a modified master test where they can do, treadmill or the modified 3 steps up and down exercise in a controlled way when you have all the setup that allows you to take proper and prompt action. The problem with the diagnosis, of course, is that in many cases it remains a diagnosis of suspicion because it's so difficult sometimes to duplicate all of the characteristics that take place, particularly with antigen dosing and the timing and all the circumstantial modifiers. But if you suspect it, then if you wait 4 hours after your meal or if you don't eat for that time, you're probably safe, even if you are an individual prone to this entity. And by the way, it happens with not only wheat, but other proteins as well.
Sure. So, Ivor, this is again for you. How should we approach serology-negative patients that have celiac disease? That's something that we know that occurs. So how do you manage this situation in terms of diagnostic follow-up?
So these are people who have symptoms of negative serology. You do a biopsy, and they have positive biopsies.
That's right.
I presume that's what the person's asking. Absolutely. Those individuals, I think, warrant a full gluten-free diet, and if you have a good resolution of your symptoms based on the gluten-free diet, that would confirm the diagnosis. In fact, if you look at the original recommendations for diagnosis of celiac disease, you had to have symptoms, an abnormal biopsy, and a positive response to a gluten-free diet, that the symptom resolution occurs, and that was sufficient to make a diagnosis of celiac disease. Serological tests could be used to confirm or to support the diagnosis, but they weren't suggested as being absolutely necessary. So that situation did exist in the past, and I think I would base it purely on the response to the diet.
All right. So there is a question about the old anti-gluten antibodies. So, and that's probably for me because it has to do with the gluten sensitivity. My understanding is the anti-gluten antibodies are not sensitive specific and do not obtain to this test. In patients with questionable gluten sensitivity, is this the test becoming a helpful tool? Well, let's be clear. This, as Dr. Hill mentioned very clearly, this test is totally useless for celiac disease. The presence of anti-gluten antibodies, it just tells us 3 things. The individual is eating gluten, number 1. Number 2, somehow gluten or its partially digested fragments come through the intestinal barrier and pass on the other side in the lamina propria. And number 3, the immune system does its job, sees a non-self antigen and will mount an immune response that will translate in the presence of these anti-gluten antibodies. That's the only thing that we can say. And this can happen in wheat allergy, in gluten sensitivity, in celiac disease, in gastroenteritis that has nothing to do with the gluten-related disorders and so on and so forth. So the reason why people there eventually look at the anti-gluten antibodies in gluten sensitivity is because we don't have anything else. But they are not a deal breaker, not for sure a absolutely necessary way to diagnose gluten-related disorders. I have one more question for Ivor. Sensitivity and specificity of TTG IgG. If TTG IgG and IgA, and if you have TTG positive, IgA normal, and the endoscopy negative, what do you do with that patient?
So this is a TTG IgA negative, TTG IgG positive, and a normal biopsy.
And there's no IgA deficient.
And not IgA deficient, absolutely. Okay, so the first thing I would say to that individual is you get what you ask for. If you do tests, it's like Kathy DeAngelo said, you need, it's like picking your nose in public. You need to know what you're going to do with the result before you start. So I wouldn't have asked for the TTG in the first place. But having got that situation, I would not treat that individual as having celiac disease. I don't think you've got any evidence to support that diagnosis with a normal biopsy and a negative IgA.
Okay, Stefano, are there cases of celiac disease occur in DQ2 and DQ8 negative individuals?
That's a very interesting question. In fact, if you read several series, you would always find that, well, maybe between 1 to 5% of the celiacs in large series actually are DQ2 and DQ8 negative. So the answer, according to the literature, the official answer is yes, you could have rarely this occurrence, although it's extremely uncommon. My personal opinion is that it's kind of hard to conceive from a conceptual viewpoint that you can be celiac without possessing those heterodimers that are needed to present gliadin peptides. Indeed, Bob Anderson, who had published this abstract a few years ago at the DDW, made an investigation in Australia. They represented a series of celiac patients, and again, they found like 3 or 4% of them were negative from DQ2 and DQ8. So what he did subsequently went back and looked case by case to the few patients in his series that actually were classified as celiac, being DQ2 and DQ8 negative. Well, sure enough, he found at the end of this careful review of these single cases, none of them actually had celiac disease. The diagnoses were changed. In a couple of cases to Crohn's, in a couple of cases to Giardia infection, etc. So what I'm trying to say is that I am very skeptical when I see somebody claiming that DQ2 and DQ8 negative patients can be celiac. But that's the personal opinion. In reality, if you read several series, rarely, again, below 3-4% at the most of the celiac patients could be found in those who are genetically not carrying either DQ2 or DQ8.
Wonderful. I think that with that note, we can wrap it up. This has been an extremely stimulating and interesting webinar, both in terms of presentation and quite interesting questions. So I want to thank, of course, all my colleague speakers, all the participants for their active participation. I want to reiterate and take again the opportunity to thank both the NASPGHAN Foundation and Quest Diagnostic that made this webinar possible. I want to remind everybody that if you want to have CME credit, please click on the link below the window so that you can have credit for this webinar. And again, thank you so much to all the participants and the speakers to have made this webinar a success. Thank you and have a good night.